Hi, good morning, everyone. Welcome to our heart-to-heart conversations about peer support. Today, we're going to be talking about the role of self-disclosure in the recovery process. I'm Ann Whitman, and I'm the lead peer consultant at the Cambridge Health Alliance CBHCs. And I'm also a lead peer consultant at the MGH Center for Psychosocial and Systemic Research. I'm here with four of my colleagues from the Cambridge Health Alliance CBHC. Sarah Stoddard-Gunn, who's the lead clinician. You want to wave, Sarah? And Michelle Onisimo, who's a recovery coach. Paul Bradford, who's a peer specialist. And Valeria Chambers, who's also a lead peer consultant at the CBHC and a colleague of mine at MGH Center of Excellence. So I want to get started today by asking each one of you how, when, where, and to what extent you share your lived experience and begin the conversation. So let's start with Sarah. You're the lead clinician and been at the CBHC since their inception. What are your guidelines for self-disclosure in your role as a therapist?
Yeah, it's a good question, and it's something I talk a lot with my trainees and my colleagues, and I think a lot about myself. I'm a licensed independent clinical social worker, and as such, uh, boundaries are a big part of, and self-disclosure is something that I have to reference back to the our ethical guidelines and also legal guidelines. There are times when I will self-disclose to patients, but it's often a fraught process involving a lot of thinking, sometimes seeking out a supervision from a colleague. But there are times when if in my clinical judgment I am disclosing to help a patient, or it may either be to help connect with a patient or to provide feedback. And if I've done a lot of work scrutinizing myself to make sure that I'm not disclosing for my own needs, then it can be appropriate. There have been times that with certain patients when I've been able to disclose that I am a parent of a child who has dealt with kind of mental health and neurodiverse challenges. There have been a couple of times when I've been able to share that, but I need to be really careful about scrutinizing myself and making sure that I'm really putting the patient's needs first, and also that I'm not creating a blurred boundary, because I'm acting as a therapist and I'm not a peer. Even though sometimes I may be a peer, but I'm not acting in the role of a peer.
Well, that's very thoughtful and interesting perspective, Sarah. I want to turn next to Paul. Paul, you and I have known each other for 2 years. We've been working together at least 2 years. And I know you've been in the field for 25 years. You have a great reputation for connecting with clients early on in their recovery process. So I wondered if you would share your story about how you share your lived experience, and tell us a little bit, maybe what you've learned over the past 25 years.
It's interesting that you talk about the different ways I've looked at it over the years. Sarah talked about typical procedures for a therapist. And I think my original supervisor was a therapist. And it took a long while for him to be comfortable for me to share much. And he kept emphasizing boundaries in one way, and I'm used to working as a peer, so I'd have to push back. And it was a little bit troublesome. It was also a different time, and I think the whole world of mental health was a little unsure of what peers could do and what peers should do. We come out of the recovery movement where it's more acceptable to share. So there's been this change. But as I've gone along, I've also discovered that less is more of my disclosure as possible. I don't want to give my story. It's not about me. It's about them. But I want to establish that I'm not a therapist. But that doesn't mean I can't be as helpful as a therapist. I'm not a psychiatrist, but that doesn't mean that I can't be as meaningful in their recovery as a psychiatrist is. So it's a way of introducing the idea that a peer is a member of the team, an important member of the team, important member of recovery. And if I can establish the fact that I can relate to the idea of being a peer, that's the first thing. I'm careful about sharing things because I'm careful about not giving advice, and I'm widowed, so I have shared that because I think that's relevant, and I think that's an important experience in somebody's life. But the main thing is that I remember the point is to establish rapport with somebody, help them understand the difference between my role and the role of a therapist or a social worker or a caseworker or a PCP or a psychiatrist, and to encourage the fact that you've got all these people and they all do something different.
Oh, that's very interesting how you've evolved over time. And I wanted to turn next to Michelle. We've been working together for over 2 years, and I know you've been in the field for a long time, and you have a great reputation for engaging people that are early in their recovery process and struggling with addiction. So I wondered, how you share your lived experience and how that's changed over time.
Sure. Thank you for that. I think that when we first start in these peer roles, it's very unclear, or it was very new when I started. I think that's why my mindset has changed from then till now. I think a lot of us who get into this role, especially as a recovery coach, I know for myself, I share with everybody, obviously, that I am a woman in long-term recovery. Excuse me. I feel like obviously that helps. It helps knowing that someone that can relate to, the people we're meeting with, they know that they have clinical and then they have another peer is definitely helpful. If I had this role for me when I got sober, who knows, I probably would have even longer than I have today. But I think that when I first started, it was more of me telling for me, and kind of like it was definitely more of a selfish reason. I now, through time and experience, learned that, like Paul said, less is more. I definitely try and establish that safe space and that rapport with them and want a connection for sure. I want them to trust me, but that comes over time. With certain people, you do find a different connection, and like you know the feeling, like if there is a time where you share a little bit more or not. I definitely, my number one thing now is how is this going to help the patient? Like, I assess the need, and then I always think, well, how is this going to help them? How is this relevant to the situation? Is this going to hurt them in any way? Or is it going to hurt myself also? I have to make sure that I keep that in up front also. What are they going to get out of knowing, whatever part of my story? And sometimes I share too, if I do give a little bit more, it's because I want them to know that they're not being judged, and we could say it over and over that this is a judge-free zone, but they still sometimes will feel it. There's a lot of shame and guilt and things that happen when people are in active addiction. And no matter how many times you tell them, like, that comes with that lifestyle, they still feel that. So I feel like sometimes if I do give a little bit more, again, that's me thinking of them, this is going to be their gain. They're not going to feel as judged. They're going to feel that I am someone that they can trust and relate to and feel more comfortable with. And then they will, keep coming back to me and want to continue with treatment, which that's the goal. And so it's basically just now over time and experience. It's just making sure that I'm protected, they're protected. My mindset is just, how is this going to help them? And I want to always think of, those clear boundaries from the beginning. So, uh,
That's very interesting, Michelle. And also that you share a little bit more when you're trying to combat stigma. That for me clearly helped to have a peer to deal with the tremendous stigma that I was feeling. So I appreciate that. Valeria, you and I have worked together for 7 years, and I know you to be one of the best trainers of peer supporters. So I'm wondering, there's been a lot talked about the decision making that goes into sharing one's lived experience. Can you talk to us a little bit about the benefits of mutual sharing and also comment on the differences between listening and active listening?
Sure. Thank you, Anne. I think the key word there is mutual sharing. But our sharing, as people have said already, really depends on where the person is at. Listening to them, finding a way to develop that rapport, help them feel comfortable, but following their lead. Maybe the person is very talkative, has a lot of questions. Um, then I pull back and really let them express themselves and find ways to communicate that I'm hearing and seeing them, whether that's eye contact. Now, some people are not comfortable with eye contact. If I notice that, then I don't push that. Um, Body language, smile. I try to match the mood of the person more or less. Like, if they're really down and the energy is just so low, I'm not gonna come in like be all like perky. Um, so I guess there's kind of a mirroring and but the goal is to help the person feel comfortable to talk about what they feel they need and want so that I can sense and discover what I have to offer and how and when and where. Active listening is about not just quietly listening like you're a fly on the wall, but to let people know that you hear them and find ways to validate what they're saying or experiencing, um, helping them see that you're not just sitting there and could care less. So, as people have said, you may find yourself sharing a bit more about your experience or a bit less. It's really taking the time to discover what the person's needs are at that time.
Well, I can see this is a very nuanced process on both the therapy side and the peer support side. Sarah, you've built the CBHC from the ground up, uh, and you've had peer specialists, recovery coaches, and family partners. Um, I'm wondering what you've learned about how a larger healthcare system like CHA could introduce and accommodate this new concept of mutual sharing to support the individuals you serve. What's worked, what would you like to see happen in a larger system when integrating peers?
working to welcome peer voices and peer leadership into our teams has really been a game changer. And I think particularly as Paul was our first peer, and we've so appreciated moments when, as clinicians, we are in a team meeting and we start to fall down the rabbit hole of focusing on diagnosis and current symptoms. And Paul, and also Michelle does this often in our team meetings, is get everybody to refocus on the person, and the person's situation and their lived experience. And sometimes our peers they'll use their lived experience not just with patients, but in team meetings to just talk about their own experience, which does sometimes shock us out of stereotype as clinicians, or focusing just on the here and now and not on the whole picture. So that's been huge. The other thing, and an area that I'm really hoping we can advocate for as a larger hospital system, is that we don't have enough peers and we don't have enough of a peer voice. Both Paul and Michelle serve most of their time in urgent care, but both of them are on a team 1 day a week in our regular outpatient department. And I really wish we could get more of that going on, because part of our urgent care, I see our peers as there are bridges and there are ambassadors to help people move from urgent care when you're really in crisis, and then help people move from that crisis point to a place of more stability and to have that wraparound care and help. And I think that's an area where I think peers shine, even in crisis, having the peer available to help with when someone's grappling with the decision about whether or not to go to a higher level of treatment, or if someone's on the verge of, do I want to leave right now and use, or do I want to try to take a really big scary step and try to get some medical care or get myself into detox. That's huge, but it's also huge to be in a space where you can lead groups and make connections, and start to launch. So this is I think this is a phase 2, is to find some funding and also convince the hospital systems of the value of peers.
Yeah, well, that's quite a testament to peers, and I'm looking forward to phase 3 or phase 2. So thank you, Sarah. Valeria, the CPS training has some guidelines for sharing of lived experience that is called RAPTOR. It's an acronym, and I'm wondering if you could tell us a little bit about what these guidelines are and what RAPTOR stands for.
Sure, Anne, thanks. You know, you hear that word. I don't know who came up with it, but it does sound like a dinosaur. So once you hear the word and the association, it really sticks with you. But it helps us remember key points. The R stands for risk to self, as people have mentioned. Is what I'm sharing too risky for me at this time? A, who is my audience? And what you share will differ depending on your audience. So if I'm sharing with, say, talking about peer support and the role and the values with a group of clinicians, I share in one way. If I am sharing with other seasoned peer supporters, I can go deeper. If I'm talking to, a group of high school students, then I have a totally different share. And people will find that you have different recovery stories and different blurbs for different audiences, different times. Um, let's see, the P I covered pretty much is for purpose. What is your purpose there? T, how much time you have. That is huge. I'm going to be speaking to a group of Brandeis students on the psychology of disability. And I've been asked to speak for 2 hours. So I'll have a long time to talk. Other times, do a quickie, 5 minutes, 5 to 7 minutes. Um, but if you know the time, you can kind of decide, okay, these are the things that I want to cover. Also, time in terms of, am I speaking too much? Am I allowing the person that I'm supporting to speak? Am I hearing them? As Michelle said, am I kind of taking over? Um, O is just as Michelle said. Am I speaking truly for others' benefits? Or am I speaking to hear myself talk? Or, because I feel really good about something and something that happened and I want to share it. But maybe that's not the time to share it. And final R is risk, and so important, risk to others. Is what I'm sharing totally off the mark? Am I sharing my trauma experiences that are way too graphic or not appropriate for the situation? Or I find, for instance, given everything that's going on in the world, I don't want to share my opinions or my fears or my concerns when I'm hearing from the person that they are totally freaked out, you know, can't, listen to the news, um, then I'm not gonna go in that direction. So it really depends.
Well, thanks so much for outlining raptor. We can remember it as the dinosaur. So thanks everyone for your ideas and input. It's clearly a very complex decision as to what you share and when you share. And I appreciate all your input and Sarah's input about how systems can change to accommodate peer work. We're going to turn now to audience questions, comments, or discussion. So that would be great. I'm opening the floor to the audience.